Pooja Puli, along with my partner Dr. Sindhu Umesh Madam, will be coordinating the most important topic whose difficulties are faced by almost every obstetricians, that is delivering fetal head during C-section and troubleshoots by Dr. Shailendra Katakdon sir. Welcome you all on this third webinar of OBGY Bonanza series on behalf of Nima OBGY Society Central. We have already seen how much theoretical and practical knowledge we have gained from the earlier two webinars. This is an excellent initiative taken by Nima OBGY Society Central to bring forward such webinars with excellent topics from most reputed and excellent speakers. Now, Nima OBGY, that is National Integrated Medical Association, Obstetrics and Gynecology, India, aims to impact education, supporting and protecting the character, status, and interest of the integrated medical profession. Its objectives is to spread knowledge and to foster education in integrated obstetrics and gynecology, to encourage and participate study in and research in field of obstetrics and gynecology, to promote services for the betterment of health and community, maternal and child health, to organize and participate in field camps, to carry out surveillance and specific research projects, etc., and many more like this. Before going towards our session, I would like to give a very few instructions to all the delegates. Please keep yourself muted during the session. If your mic is found disturbing, interfering speaker, you will be either kept in waiting room or removed from the session to maintain the decorum of the program and to avoid the disrespect of our honorable speaker. And lastly, at the end of the session, put your question in chat box or raise your hands. Now, moving towards our session, before starting, I would like to do Dhanvatari Stavan with due permission from all the dignitaries present here. Om Namo Bhagavate Mahasudarshanaya Vasudevaya Dhanvantaraya Amrut Kalasha Hastaya Sarva Bhaya Vinashaya Sarva Roga Nivaranaya Trilokpataya Triloknataya Shri Mahavishnu Swarupa Shri Dhanvantari Swarupa Shri 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 Aushad Chakra Narayanaya Namaha. Now let me give you introduction of the topic which we are going to do. Caesarean section rate has been on rise. It is commonly perceived as a simple and safe alternative to vaginal birth. One of the major advantages of C-section delivery is that the fetal injury through birth canal is eliminated and controlled delivery of baby under direct vision is accomplished. However, there are situations during C-section where delivery of fetus may be difficult. This may cause maternal and fetal complications. There are situations in which delivery of fetus is not smooth and difficult, or traumatic delivery would defeat the very purpose of C-section. To avoid such mishaps, anticipations of potential difficulties and planning in advance can be fruitful. Hence, we have came forward with this topic, and we have honored to have Dr. Shailendra Katakdon sir as our guest speaker. We also welcome all the dignitaries present here today. Dr. Vinayak Temburnekar sir, President Nima Central, Dr. U.S. Pandey sir, Secretary Nima Central, Dr. Ashutosh Kulkarni sir, Treasurer Nima Central. I would also like to welcome Dr. Kamini Dhiman ma'am, President Nima OBGY, Dr. Priyanka Nakade ma'am, Secretary Nima OBGY, and Dr. Vishnu Bhavane sir, Treasurer of Nima OBGY. We welcome all the delegates present here today for this session. Before starting, let's take a moment to introduce our guest speaker, Dr. Shailendra Katakdon sir. I would invite Dr. Sindhu madam to give a brief introduction about sir.
Thank you, ma'am. Thank you, Dr. Pooja. Myself, Dr. Sindhu Umesh, really am privileged to co-host this particular third webinar of the Bonanza series. And it is my privilege to introduce today's guest, Dr. Shailendra D. Katakdon sir, on behalf of Nima Obgy Society Central. Sir is professor and HOD of College Vasantrao Patel Ayurvedic Medical College, Sangli, Maharashtra, and graduated from Government Ayurvedic Medical College, Nanded, Maharashtra. Sir pursued his post-graduation in PTSR in the same college and presently now pursuing his PhD studies in the same college. There are more than 5 international publications in his name. Sir also has national publications more than 10. He's a resource person of ROTP and various national and international seminars. Sir also excels in academic facet with his teaching experience of more than 21 years. And Sir is outstanding Ayurvedic surgeon to perform various open and laparoscopic surgeries throughout the year. He expertises in the field of post-operative and post-labor Ayurveda protocols and effectively been practicing since 20 years. So friends, sit back and get up with a wave of zeal to hear to Sir's talk. Sir, now we invite you for the most awaited talk, and now it's over to you, sir. Thank you.
I would like to say thanks to Dr. 𝘿𝙀𝙀𝙄𝙑𝙀𝙄𝙑𝙀𝙄 sir. He is one of the renowned and very experienced one in his surgical fields also and academics also. So welcome you, Dr. 𝘿𝙀𝙀𝙀 sir.
Thank you, madam. Am I audible?
Yeah, you are.
Yes,
voice
sir.
Voice is clear?
Yes, sir.
Okay. Thank you. First, I would like to say thanks to Nima Obgy for giving me this wonderful opportunity. See, today is 26/11. We have 14 years back, we had very bad experience. Some militants were attacked Bombay, so that Friday is called as a Black Friday. So I am paying my tribute to all the martyrs who were put down their life on 26/11. Today again it is important that our constitution in 26 November 1949 we accepted our constitution. So today is the Indian Constitution Day. So I would like to invite you all for my today's talk. I would like to say thanks to Diman madam. She is the president of Nima Obgy, Nakade madam. She is secretary, and Dr. Bhavani sir. And I would like to welcome all the dignitaries, all the senior persons who are here to listen this workshop. So I am going to present my topic. My topic is delivering fetal head during C-section and troubleshoots. See, I would like to share one experience. I was working in Sawantwadi. Just I had joined my lectureship. So I went with my anesthetic at one rural hospital. That hospital was government rural hospital. There was one lady gynecologist. I'm not going to disclose her name. So she going to operate the LSA. She was going to operate one LSCS. My anesthetic told me that he is a BMS gynecologist. So he came with me. So we have a chat, and she started doing the cesarean section. She told me I don't need any kind of help. So I walked to that hospital and sat on the seashore. After 15 to 20 minutes, one ward boy came to me. He was running. He was very frightened, and he asked me, "Your anesthetic called up. Your anesthetic called up." So I went there. What I saw, both hands of the baby are protruding from the wound, and she could unable to deliver that baby. I saw that scenario. Incision was very small. Patient was moderately obese, prime gravida. She took for the elective cesarean section. And at that scenario, and after seeing that scenario, I was a little bit frightened. What has happened? First, I noticed that incision was very small, so I put gloves. I made the incision a little bit longer. I cut the muscle transversely. I had made the inverted T on the uterus. I reposed both hands and I delivered that baby. And after that, that gynecologist became my very good friend. So what I'm saying, see, everybody, any person need help. And after that, I had also experiences, bad fetal extractions and everything. So I had talked with Dr. Priyanka madam, and I told her that I would like to take lecture on this delivering fetal head during C-section and troubleshoots. Okay, this is about what my first experience when in maybe in 2002, that time I was in Sawantwadi. Okay, I will start with my presentation. My hero is Ian Donald. He has written the book Practical Obstetrics. I'm very much fond of him. In his preface, he dedicated book to all who have known doubt, perplexity, and fear as I have known to them. So everybody, as an obstetrician, everybody go through doubts, perplexity, and fear. Still, I am having doubt, perplexity, and fear. To all who have made mistakes as I have in my this 24 years career, obstetric career, I have made a lot of mistakes. I went through a lot of troubles. Yes, and to all whose humanity increases with their knowledge of this fascinating subject. This was the line in the book of Ian Donald. So I will start with this. A caesarean section, the word caesarean section, it has some history. There was one Roman law made in the time of Numa Pompilius. He was a Roman emperor, and in that law, he gave an order that to cut open the abdomen on fated or a dying woman. In our Ayurvedic Samhitas also, in the management of Mood-Garbha, the same thing has been written. What in our textbook or Samhitas has written? Bastamara vipannaya kukshi praspandate yati tat kshanat janma kale patet tato patet uddharit bhishakaha. When the woman, maybe she's fated or maybe she's dying, and her abdomen is praspandate, kukshi praspandate yadi. Her abdomen, suppose her abdomen is pulsating, then you have to cut open the abdomen and extract the fetus. So this what is written in our text. Another thing, after bastamar means what? The cutting goat. If you have seen the cutting goat, the goat of abdomen is pulsating like that. Bastamara vipannaya. Okay. After that, it is written by Shishrus. It is written in the Shishrus Samhita Nidan Sthan. And afterwards, Ashtang Hridaya and Ashtang Sangraha, they has written that Basti Dware Vipannaya, not Bastamar. Here they had written Basti Dware Vipannaya Kukshi Praspandadeyati Janma Kale Tatakshana Patet Uddharet Shishum. In first verse, in the first shloka, there was Bhishak. In the second shlok, which is written by Ashtang Hridaya, Ashtang Sangraha, there was Kukshi, Shishum. Okay, Janma Kale means what? Near term. If suppose that woman is fated or dying woman. The word scissor, the word caesarean, it came from the word cedere or caesura. This is the Latin verb. And the section again, it is a Latin verb. And the meaning of section and scissor, that is the to cut. This is all about the history. And the father of caesarean section in the modern obstetric, the father of caesarean section is Francis Morceau. And the father of lower segment caesarean section is Munro Kerr. Okay, this is all about the history of caesarean section. Now, leaving with the history, I am going to explain the steps of caesarean section. In last lecture, we had seen one video. It is demonstrated by Kamte sir. He had explained very nicely about each and every step of cesarean section, its importance, troubleshoots, and everything. So today I'm going to talk a little bit about only extracting fetus and its requisitions. So opening abdomen. As I am a senior, just I told you that since 25 years I'm doing all these kinds of surgery. I came to know that a little bit broad incision or the elaborate incision or liberal incision can solve a lot of difficulties. So while opening the abdomen, if in the primary gravida, suppose she is obese, if it is in the thin patient, it's okay. But in obese patients, the patients who had strong abdominal muscles, in the patients of previous cesarean sections, in the patients of previous surgeries, in the fibrosed abdomen, fibrosed scar. So while opening the abdomen, always make the liberal cut. Okay, make the adequate incision or just more than the adequate incision. 2 centimeter more incision. If the incision is more than 2 centimeter than a regular incision, nothing will happen. It requires only 2 stitch, but it can prevent lot of complications. So while opening the abdomen, just open it liberally. Again, it depends upon the patient. If suppose patient is thin, baby is average, that time you can have that advantage to make a adequate incision. But suppose the condition is otherwise, then the incision of the abdomen should be more than adequate. Next thing, after the opening the abdomen, after the skin incision, you have to separate the rectus sheath in the scarred abdomen. You have to separate the rectus sheath adequately. You have to separate the muscles again adequately. So more than adequate is important in the opening abdomen. Incision on uterus, I have seen many times people inside the uterus either too low or too above, but then in the lower segments, if the incision is too low, suppose the incision on the uterus is too low, the length of incision, it remains less, it can cause the trouble in the extracting fetus, or there are chances of extension. Lateral extension is more when the incision is too low. If suppose the incision is too high, and suppose lower segment is not formed, not prepared, that directly you go into the upper segment. You have to cut more and more uterus. The bleeding is more. Again, you got thick segment. You may face problem while the extraction of fetal head. So in both conditions, incision on uterus is very important. Again, incision of uterus is very important if there are bladder is adherent, okay, or the ventrofixed uterus. So incision on the site of incision on uterus is very important. Again, after adequate mobilization of uterine incision, the delivering of fetal head is again, it is very tricky. What I say, we can get help while opening the abdomen. We can get help if suppose there is a bleeding, suppose there is a flabby uterus, suppose there are extensions, suppose there is a lateral extensions. For any complication, we can get help. We can call for help. But if suppose you incise the uterus and you are trying to deliver the fetus, then you cannot seek for help. You have to do it. You have to do it on your own skills. So delivering the fetal head, it is very, very tricky. You got little time, maybe 6 to 7 minutes. If you are going to if you are not delivering during that time, then you may land up into complications. So delivering fetal head is very tricky. And after that, delivering the baby. Anticipate difficulty. So see, before taking the patient to cesarean section, you have to anticipate the difficulty, what will going to happen in that patient. Anticipation is always better than creating problems and then again tackling it. So anticipate difficulty. If suppose the patient is morbid, there is a morbid obesity, again always think for the difficulty in the extraction of it and difficulty in the cesarean section also. Previous surgeries like previous cesarean section, ventrofixed uterus, lower segment leiomyomas, we have to anticipate the difficulty. Polyhydramnios, especially in polyhydramnios, there is a high floating head. You may counter difficulty in the delivering head. Anterior wall low-lying placentas, high floating head, extreme preterms, big babies, deep transverse arrest, persistent occipito-posterior position, transverse lie, malpositions, complex presentation, conjoint twins. In all these things, we have to anticipate the difficulty and we have to prepare ourselves accordingly. Not just open the abdomen, open the uterus and trying to extract the fetus. Many times you may feel difficulty in doing cesarean section in all these patients. So always anticipate, be prepared. Okay, be confident, be prepared, but anticipate difficulty and accordingly you have to prepare yourself. You have to prepare your staff. You can get extra help before starting the surgery. You can call some senior person. You can call your colleague for the help. So at the time of anticipating, you can seek for help. You can manage help. But once you have started, then nobody will come to help you. Mistakes. What I shared one experience. I experienced a lot of such mishaps. I have been working with so many obstetricians, maybe more than 25, 26 obstetricians. So inadequate abdominal incision, it is a key for many complications. Inadequate dissection or separation of rectus sheath. Inadequate separation of. Sometimes the rectus sheath is very much fibrosed. We could unable to separate it from the muscles in the previous cesarean sections or previous surgery. So the band are going to trouble you in the extraction of fetal head. Inadequate separations of muscles. Sometimes muscles are very much adherent to each other. We cannot get space to open the peritoneum. So inadequate separation of muscles. Wrong site of incision on lower segment of uterus. Just I covered these things. Attempt to deliver head without flexion. I had seen so many obstetricians. They open the uterus, they put their hand and they're trying to deliver the baby. Wait till the flexion of fetal head. This is the key of smooth delivery of fetus. So attempt to deliver the fetal head without flexion. It can cause problem. It can cause troubles. Mistiming of fundal pressure. If the head is not flexed, if head is again rotating, at that time you asked for the fundal pressure, then again the axis may go wrong, and there are chances of rotation of fetal head and fetus also, and you are going to face the troubles. So mistiming of fundal pressure. When you are confident, when you are comfortable, when you feel that yes, this head is flexed, that time only you ask for the fundal pressure. So mistiming of fundal pressure, again, it is a key point. Two key points: attempt to deliver head without flexion and mistiming of fundal pressure. Last thing, again, it is very important: frantic and panic attempts without any orientation, with unexplained hurry. Frantic attempts. If suppose fetal head is not coming, that operator become very much panic, very much anxious. Sometimes that surgeon becomes blank. He know what to do and what not to do, and that time he's doing something very unusual, and he may face the problem. So the frantic and panic attempts without any orientation.
I think we have lost the connection. Dr. Sindhu?
Yes, ma'am.
Yeah, please call.
Yeah. Yes, ma'am. I'm doing it. Yeah, ma'am. Hello, sir. Hello, sir. I'm calling sir, ma'am. He is unable to receive the call, I suppose. I'll repeat, ma'am.
Either you can put a message. Dr.
I'm
Sindhu?
sorry, not there actually.
Yeah? Yeah, Archana?
Ma'am, sir नहीं है.
No, you just message him.
Yeah, okay. Okay, ma'am.
Yeah.
We will rejoin again, ma'am.
Yes, definitely.
Ma'am, I can see, sir. He is present, ma'am.
He is present, but we are
But
unable
is
to hear him.
Yeah, ma'am. I'm calling him, ma'am. He's not receiving the call.
That we are, yeah.
Yeah, ma'am.
Have you messaged him, Dr. Sindhu?
Ma'am, I called sir, ma'am. He didn't know that his connection was off. So he's joining again, ma'am. He's rejoining.
Okay.
Yeah, ma'am.
Hello?
yes, sir, we can hear you.
Yes, sir.
Yeah. Okay.
Please
Sorry.
continue.
Mhm.
That's okay, sir.
It's okay.
Okay, where I am at the troubleshoot or where?
No, sir.
Hello?
Previous
So
one. Previous
the
one.
previous slide, sir.
Mistakes.
Almost
Yes,
done.
yes.
Ha.
The last.
Okay.
The last point
Last
you were.
Panic attack.
frantic and panic attacks. Okay.
Yes,
I will
yes.
go to next slide. Okay. Then troubleshoots. Speaking about troubleshoot, anticipate complications, learn from our mistakes, practice, execute, analyze, and set SOPs. So all these things are very important. Anticipation is very important. Learning from our own mistakes and others' mistakes. Again, it is very important. Practice good things. Practice what you have learned. Execute when it is needed. If suppose you face any problems, you execute it and and solve that complication, solve that trouble. Analysis. Be a critic of yourself. Always be a critic of yourself. Always analyze what went wrong, what should have been done better, each and everything, and set SOPs. You can get SOPs from your colleagues, for your senior, for your bosses, for your teachers. Set some good SOPs. So for the troubleshoots, anticipate, learn, practice, execute, analyze, and set SOPs. It is very important. Learn basics from a proper person. This is very important. If suppose I have learned C-section from a person who is doing a cesarean section very in a rough manner, very hastily, he don't use to respect the tissue. And suppose I have learned all these things from that, I have to reciprocate same things, and I may commit some complications. So learning basics from a proper person, again, it is very important. Another thing, respect tissue. Respecting tissue or dissecting tissue is very important. If you handle the tissue roughly, then again it is not going to help you. Follow the basics religiously. Again, it is very important. Learn basics from a proper person and follow them religiously. So they are going to help you into the complications, into problems. Again, avoid cut shots and hurry. Many times, what happens due to the more or less, due to many surgeries, we try to cut shorts, we try to skip some steps. So don't do that. Don't make it in a hurry. Enjoy surgery. Okay. Avoid cut shots and hurry. Impatience is mother of all complications. Don't be impatient. You have opened the abdomen, you have started the surgery. Don't think about anything else. Just be there. Surgery is like a meditation. If you have started it, then do it religiously, do it calm and quietly. Give your 100% to that patient. So just don't be in a hurry. Impatience is the mother of all complications. Refrain yourself from doing something heroic. See, I am telling this. What happens sometimes, people trying to do something heroic, trying to cut short some steps, and in one or another case, they may commit into the complications. So refrain yourself from doing something heroic. Be open-minded to admit and to correct the mistakes. If you have done something wrong, okay, fine. Mistakes happen with each and every person. So nothing wrong in that. Be open-minded. Correct the mistakes. Improvise yourself with each and every procedure. That is very important. Be open-minded. Correct mistakes, because you are going to deal with a patient. And if suppose you are doing same mistake again and again, you are making complications, nothing is going to work nicely. So improvise yourself. One of my boss, he used to open the bladder in every fourth or fifth patient in previous LSS patient. So what I have learned from him, to repair the bladder. So if suppose I open the bladder in any patient, I could able to repair it myself. So learn from the others' mistakes. Be a good observer. That's very important. If you are not doing anything, if you are not doing surgery, some another person doing surgery, just be a good observer. Observe him, his good things and his bad things also. Be like a blotting paper. What is how to be like a blotting paper? Absorb whatever there is a good, just absorb it. Respect your patient, maintain her dignity, avoid any kind of mental and physical trauma to the patient. This is very important. Then procedures, my procedures and the manuals to deliver the baby smoothly, nicely. Plan appropriate maneuver to deliver the head. This is very important. Plan appropriate maneuver. If suppose the patient is obese, if there is a high floating head, or if there is a deep engaged head, just think about the maneuver in your mind before opening the abdomen. Just plan the appropriate maneuver to deliver the head. Application of obstetric forceps for controlled head delivery. It will help in the high floating head, deflexed head, transverse lie. So judicious use of obstetric forceps. Use ventouse in selected cases. Again, these both instruments are very important in the C-section. Making inverted T. Making inverted T, again, it is in the high floating head, in transverse lie, in modified Patwardhan. Just make a liberal T. And when the space is less, in any kind of difficulty, you can make inverted T incision. Delivering by internal podalic version. When I was in Sawantwadi, we used to do these two maneuvers, making inverted T and delivering by internal podalic version. We do it often, very frequently. Modified Patwardhan technique for the deep transverse arrest, lower vertical incision on lower segment. I have never tried this lower vertical incision. I'm happy with the inverted T and classical C-section. Then this is the video of, this is a simple video, how to extract the fetal head. See, I have not separated the bladder. I have not opened the EB fold. See, incision on the lower segment. Incision is liberal. The length of incision is more than 5 centimeters. Then I am making small and small nicks. Meconium strained liquor is there. So this is the case of previous C-section. Cord was popping. Just put your hand in between the fetal head. Just lift it. No need of fundal pressure. And I always deliver anterior shoulder first, and then I will go for the posterior shoulder. No hurry. Nothing has to be there. So this is the simple extraction. Make adequate incision on the lower segment, first thing. Then extend upwardly. Extend the incision upwardly like a smiley with 2 fingers. Then put your 4 fingers between the lower flap of lower segment and fetal head, and just elevate it. It will come automatically. There is no need of fundal pressure or nothing else. This is the another video. It is in the high floating head. See, in this case also, this is also case of previous C-section. I have not separated the EV fold or separated the bladder. Liquor is more and more a bit polyhydromenous. Drain the liquor. Don't do anything. Just don't do any heroic things. Just be quiet. Lift the upper flap like a smiley. I'm doing it very gently. If you do in a rough manner, then automatically there is extension of incision. Just bring the head into the incision site. Just lift it. Ask your assistant to retract the abdominal wall. Just a little 2 strokes of fundal pressure. Then this is the case of high floating head with polyhydromenose. What I have done, I opened the uterus. I allow the liquor to drain. After the draining liquor, I just upwardly push the upper segment or upper flap of lower segment. It allows the fetal head to come into incision, and again it allows the fetal head for the flexion. When I think, yes, this head is going to flex, then I put my hand and then I deliver that baby. Okay, this is the another video, 2 videos. First one is simple, another one is with high floating. Here, this is the case of vasa previa. So while opening, see, very smoothly, I'm trying to open the uterus hysterotomy. I'm doing it very gently because this is the case of vasa previa. In the fear of tearing that major vessel, I am trying to separate lower segment, a flap of lower segment, a flap of upper and lower. See, again, just lift, pulling up the upper flap of lower segment. Put your forefingers in between lower flap. Just ask for 1 or 2 gentle strokes of mental pressure. 2 loops of cord, or cord is wrapped around the ankle of that baby. Again, meconium strand liquor. So this is another case. When suppose there is a placenta, vasa previa, interval placenta, you go gently, either go through boldly when the lip of the placenta is beneath the incision, go boldly, incise the placenta, and then extract the fetus. This is the application of ventouse. Again, the case is high floating head, previous LACS. First open the uterus, then apply ventouse. Try to apply it on vertex. Okay, rotating your finger around the cup. Make sure that no wall of uterus is grasped in between ventouse cup. So be very gentle. Be very gentle. See, the site of application of cup is exactly at the vertex. This is the ventouse delivery. How to apply the ventouse, how to pull the baby, where to apply, and in the what case. Another case, this is the application of forceps. Again, high floating head with polyhydramnios. I allowed the liquor to drain it completely, making a smiley incision, fixing the head, putting my hand in between fetal head and the lower flap, applied lower blade of forceps, then just ask assistant to hold this blade. Otherwise, make sure the blade is applied properly, and then try to extract. So this is very good instrument either in vaginal delivery or in cesarean section. So I am an old timer, so I still believe in the obstetric forceps, and I still apply. This is all about the maneuvers. One simple, another high floating head, another one with the ventouse, and this one is the forceps. If suppose, see, this is making inverted T. Again, this is the case of previous C-section. Bladder is adherent, so I'm not going to separate the bladder. I'm taking incision, making a small nick. Previous one is long, then doing small nicks till the membrane. I'm not in a hurry. Liquor is meconium strand, so you can see the making a smiley incision.
Sir, we can't hear your voice. Dr. Shailendra?
I'll speak.
Yeah.
Sorry for the technical issues. We are trying to fix it.
Hello, sir. Hello, sir. Hello.
No, I think so. Sir's network is not there.
Maybe, ma'am. He answered the call, ma'am. He told he would see to it, and I'll check once again.
Okay.
Okay,
no
ma'am.
problem.
Okay, ma'am.
Yes, sir had called, ma'am. He's logging in once again, ma'am.
Okay, no problem.
Yeah, ma'am. Hello, sir. We are audible to you.
Hello.
Yeah, ma'am. Sir is again logging off and logging in. He had called, ma'am.
Okay.
He's logging in, ma'am, again.
Yeah.
Yeah, ma'am. Hello, sir. You logged in?
I think so. Sir has not yet logged in.
Yeah, he will just.
Yeah, ma'am. I'll just call again.
Some network issue is there, but very beautiful session is going on. So please stay with us. Sir will join soon.
Ma'am, sir, he might take 1 or 2 minutes, ma'am. He's trying to log in, ma'am.
Yeah, absolutely.
Yeah, ma'am.
This is very important session, I should say. And sir is taking very nicely.
Yeah, yes, ma'am, with his personal experiences, right, ma'am?
Yeah.
Yeah, ma'am.
Until that, I think Dr. Priyanka, you can share your opinion also. or we are having very good persons here. Dr. 𝘿𝙀𝙇𝙖𝙑 sir
I
is there.
think
Manoj
yes,
Gaikwad
yes,
sir is
yes.
here.
I should say, please, Dr. 𝘿𝙀𝙇𝙖𝙑 sir.
Hello.
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 Hi, sir. You are
जी, आ
audible
रहा है?
now. Yeah, you are audible. You can carry on.
Okay. There are a lot of technical problems.
Yeah, no problem. But sensation is very nice. Yes.
Okay, thank you. See, from this video, na?
Yeah.
Okay.
Yes, sir. Inverted T. Yeah, sir.
Yeah. See, this is the case of previous 2 C-sections. See, initial incision was a little bit broad. Then I am making small and small nick. Liquor is meconium strain liquor. So lateral space is little bit less. So I'm trying to make an inverted T incision to facilitate the smooth fetal extraction. Put your 2 finger in between fetal head and upper flap of lower segment. Insinuate your 4 finger between lower segment and fetal head. Just ask for a little bit traction and deliver the fetal head. This is I have told you about 3 maneuvers. One is application of ventouse, then the application of forceps, then inverted T. I have no video of modified Patwardhan. So I'm sharing one video. See, here this is again a case of high floating head. Obese patient trying to deliver a head after taking incision, but tried for fundal pressure, lifting the upper flap, giving fundal pressure from each and every point. Still head is stubborn, it is not coming. I'm trying. It takes some time, but be patient, believe in your skills. This is all about the last. I have another one video, but I'm not going to share it. See, for a good obstetric practice or for a being a obstetrician, passion is very important. So be passionate what you have done, what you are doing, what you have to done. So be passionate about the subject and practice a lot of good things, imitate good things. In our Maharashtra, there is a Gnaneshwari. In Gnaneshwari, the great saint Gnaneshwar written that या लागी माझे ठाई अभ्यासे मिळ अभ्यासासी काही सर्वथा दुष्कर नाही या लागे माझे ठाई अभ्यास मिळ. If you are going to achieve anything, you can achieve anything by practice and practice. Okay, you can be perfect by practice. So मनोनी अभ्यासासी काही, if you practice, if you keep practicing, okay, सर्वथा दुष्कर नाही, you can get anything. आप कोई सी चीज पा सकते हो. या लागी माझे ठाई अभ्यासी में, इसीलिए मुझे प्रैक्टिस करने का हर वक्त मौका मिले. Then the precision, what you have learned. So try to be very precise, very particular, very sincere, very honest. And last thing, that is the perseverance. Perseverance is very important, and believe in yourself. So thank you for the patient listening. And I'm extremely sorry, some problem with network and all these things. 2 times I broke out network. So, and thank you for the patient listening, and thank you Priyanka, and thank you all the seniors for giving this opportunity to present myself. This presentation would have been better if I had given the uninterrupted speech. So let it be. We will
Not
do
at
some
all, sir.
we
This
will
session
do some
was too
another
good
time.
that even we don't mind about the disturbances. It was too
Yes.
good.
Okay, thank you, thank you, thank you.
Yeah, thank you, sir. Thank you for that wonderful presentation and a mind-blowing one. And with your experiences, it was an insight for our future cases, sir. In our practice as such, we would definitely remember you maybe in our very next case. Definitely, sir. So friends, now we go to the second session of this continuation is the question and answer session. And this is the very precious opportunity for you to interact with our renowned guest, interact with the most senior faculty here. So any questions you can put on the chat box or you can raise a hand. So unmute yourself and then answer the questions, ask the questions, and we are here to sort it out and sir will answer it for you. So we'll go with the questions now. So any among you who are ready? Sir, until then, sir, until our audience would ask the questions, sir, we just want guidance from you regarding the absolute and the relative indications of the upper segment, sir, upper segment section. Like when should we prefer an upper segment particularly compared to the lower segment one?
Okay, as per my experience, when in the previous C-section patient, placenta is complete low-lying or placenta previa, then go for upper segment cesarean section. And if the placenta is morbidly adherent, in the previous C-section patients, many times, often placenta is morbidly adherent to the lower segment, or sometimes it encroaches the broad ligament also. That time we have to go for the obstetric hysterectomy. So always try to do classical cesarean section. We used to again do a transverse incision rather than longitudinal incision on the fundus or on the upper part of upper segment of uterus. We extract the baby, we close that uterus very roughly, and just we go to the obstetric hysterectomy. This is what we practice.
Okay.
We never try to even separate. That placenta. Many times it bleeds very, very furiously. You can lose your patient within a minute. So involve some good persons while doing this.
Okay.
This is all about the classical section, or in the modern obstetrics, there is no role of classical C-section.
Okay, sir. Okay, thank you for that, sir. Sir, there is a question. Yes, sir. There is a question regarding the usage and the indications and the methodical steps for the application of forceps during a cesarean section.
Yeah. This is, again, it is very important question. As far as me, when I was in Sawantwadi, especially near about 2002 to 8 for 6 years. That time I was used to take a inverted T or internal podalic version. We used to take, if suppose we try for head, if it didn't come, just we cut the upper just make a T and we deliver the baby. When I came to Sangli, I'm working with one senior obstetrician. One day he faced a difficulty and quietly he applied forceps, he extracted the baby, and I realized that it is very easy rather than doing more and more invasive. So in high floating head, in the obese patient, in previous C-section patient, when the excess fibrosis is there and there is chances of slipping of fetal head, that time just be gentle, put a forceps, extract the baby. There is no chances of extension of uterine wound. Nothing will happen. Nothing problem will happen to the baby also. So this is very safe instrument to use in C-section.
Okay, sir. Sir, should we be aware of the particular position of the head of the fetus? Like,
Yeah.
Maybe it is a requisite before we apply.
Before taking C-section, always we see for the fetal hearts. Where is the back? Where is the back of the fetus? Okay, is it at right side or left side? Accordingly, you assume the fetal head or the vertex is on right side or left side. Put your hand in between the lower flap of lower segment and fetal head. you can palpate the ears and put the posterior blade of obstetric forceps. Then apply anterior blade and just extract it. There is no need of any typical procedure, typical maneuver, typical fetal head position, nothing.
Okay.
There is no need. There is no need.
Fine, sir. Fine.
Nothing will happen. Nothing will happen.
Okay, sir.
If there is a little bit mal-application, nothing will happen. It takes some seconds.
Fine, sir. Thank you, sir. Thank you for that, sir. Sir, are there any indications for performing a pervaginal examination before we perform cesarean section? If so, what are those conditions and how would our incision over the lower segment depend on this particular aspect, sir?
Yeah. If there is a deep transverse arrest, okay. A prolonged second stage of labor, you tried with the instrumental deliveries, you tried with ventos, you tried with forceps, and suppose that baby didn't come. So your lower segment is stretched up and up. If you take incision on your regular site, you may incise the vaginal wall, not the lower uterine segment, or you may go through cervix. Many times people either go through cervix or go through the vaginal vault, and there are chances of lot of extensions. So always try to take the incision above the contraction or at the contraction ring. You can palpate the contraction ring, take an incision above the contraction ring, and try to deliver the head with modified Patwardhan technique or vaginal push technique.
Okay, sir.
And what precaution we should take when if there is a Bandel's ring formation over there, how we will assess the lower segment properly and extension of the lower segment?
Extension of lower segment. To avoid the extension of lower segment, always try to make incision little bit upper.
Okay,
in Bandel's rings also?
Above that.
Try to take your incision above that ring, above that contraction ring.
Yes, sir.
You will get more and more space. Hands or shoulders are just lying beneath that ring, so you can easily perform the modified Patwardhan.
Okay, sir. Okay.
So many times we took episiotomies. We tried with ventos. We tried with forceps. Again, there is absolute or the contracted pelvics, then we have to go for cesarean section. And if there is a persistent occipito posterior position, again if you are trying to pull the vertex, then it can cause bad vaginal tear, bad extensions.
Yes.
You have to keep suturing. It is more invasive. So try to in such patients, take a broad incision on just at the contraction ring and deliver by the modified Patwardhan technique.
Fine, sir. Fine. Sir, among modified Patwardhan techniques, sir, among the modified ones, 3 are there. Which would you prefer, sir? Or is it according to the presentation and position, sir?
According to the presentation, according to the size of baby, according to the obesity, according to the previous surgery. See, if the baby is small, go with 2 hands, it will come easily. If the baby is big, then again made a inverted T incision and extract the fetus with modified Patwardhan technique. One hand, one leg, another leg, then hand, then fetus.
Ipsilateral one. Yes, sir. Okay.
Yeah.
Okay, sir. Thanks a lot, sir. Okay, sir. Sir, what are the precautions that we should take to avoid the hyperextension of the head and neck, sir, while extracting the head? How will we know that, yes, we are not doing this particular event?
Yeah. See, our tactile stimulations are developed as we practice more and more. Once you put your hand at fetal head, you realize that this head is going to give us trouble. And that time, just apply forceps, apply ventos, and extract the fetus. If suppose you are asking for the fundal pressure without any flexion, then again the fetal head keep rotating. Either it go into that corner. You're trying to make it in the incision. It will not come. It will take time. Another few minutes, you will become panic, and the total scenario become different. And at some point, each and every person will get blank.
Right, sir.
he get blank. He don't know what to do next. And that time, the maximum mistakes are happen in those time when you become blank.
Yeah,
So
sir.
anticipate, just anticipate. If there is high floating head, patient is obese, and if suppose it depends upon your physics also. If suppose I am a small person, I have less power. I never try to do with the Joko Hill. I always try with the financial incision. I cut the rectus sheath laterally. I separate muscle properly. I make adequate space, and then I go for extraction. I never try to stretch. I stretch rectus sheath and muscles in only severe fetal distress. At that time, I have to deliver the fetal head within a minute, within a half minute. That time only I prefer that technique. Otherwise, in a routine cases, I go very quietly and calmly.
Okay, sir. Right, sir. Thank you for that, sir.
So at the second stage of labor and with the impacted head, in which conditions we should safely go with the pull techniques and push technique?
See, in second stage arrest, we always know the station of head. And another tricky thing, that is the persistent occipito-posterior. The station at the +2 or station at 0 station with persistent occipito-posterior. If we go for the pull technique, if you go for the push technique, again your head delivery is going to be difficult. If the occiput is posterior, you have to put your hand below that fetal face, through the fetal head, and if your fingers are small, if you are a small person, mostly girls, but their fingers are little bit small, so their hand never goes so deep. So it remains up of the fetal head, and again it's going to create problem complications. So always make an incision on just at the worth of upper segment, lower segment, and try to deliver the fetal head by modified Patwardhan technique. Once master it is very easy. Modified Patwardhan is very easy. Actually, in deep impacted heads, a shoulder is always come after the incising the lower segment. It comes first. It is a popping at the incision site. So deliver it. But never try to deliver hand. Never try to deliver hand in high floating head. In high floating head, it is 100% it is going to trouble. You may lose baby in that scenario. So never, if suppose hand popped out, that time just take a liberal inverted T, put hand inside, and then try to grasp and try to grasp the fetal leg and extract it by internal podal version.
Also, I would like to ask, sir, what precautions need to be taken during C-section with an anterior fibroid or fibroid at the site of incision?
Try to avoid it. That's the only solution.
Okay.
Try to avoid incising. Try to avoid taking incision over the fibroid. That's the only solution. If you go through the fibroid, you have to face a lot of bleeding. The space is very less, and you are not going to exercise that fibroid. It becomes somewhat messy. Then always try to avoid that fibroid. Take incision to the lateral, make inverted T, deliver your baby quietly, suture it, and just be happy.
Okay. Also, how to extract twins baby lying both in transverse line?
Yeah. That day, Dr. Priyanka also asked this question. See, in monochorionic, nowadays monochorionic twins are very less. Always obstetrician advised. Always obstetrician advised for the termination. If suppose a patient, any baby you deliver, if first one or second, nothing will happen. There is a lot of space. Grasp the leg of the baby, any baby, first one or second one, the baby will come out, then you can deliver another baby. See, making abdominal incision, mobilizing proper muscles, mobilizing rectus sheath, making more and more room, taking liberal incision on the uterine wall. It helps in each and every procedure. So try to make it just liberal, more visible, more precise. That's what I'm saying. Don't try. Don't try to get the baby from the small incision. Nobody will give you prize. Nobody will give you prize. This is craze in the first or second residency. I have delivered that baby from this small incision. I have done this in half an hour, 20 minutes, 10 minutes. Forget about this. Forget about it. Nobody will give you prize about all these things. Just give proper justice to your patient. That is very important.
Yes, sir.
Many times nothing will happen. Many times nothing will happen. But if something happens, that you may land up into bigger problem. And you keep regretting what I have done. I should not have done these things. Always you keep regretting.
Yes, sir. Also, what is fetal pillow technique? Is it significant, and when should we prefer?
Do you know the cost of fetal pillow?
No, sir.
You are private practice. Priyanka will answer this question. What is the cost of fetal pillow? She is really rich, so she can answer.
No, sir. What is the significance?
These are called as the toys, and these toys are very expensive. So, and there is very less use of it. Very less. Okay. All these things are for the academician. Put a fetal pillow, fetal pillow, and all these things. See, if you are doing on your own with limited resources, you have to be very particular.
Yeah, right.
Try instead of getting into problem, just try to avoid it. Once you confirm that this is the outlet CPD, head is big, baby is big, it will not come from the vagina. Take early incision. Take early decision.
Also, I would like to ask.
Got it?
Yes, sir.
Sir, how liberal we should be while taking the inverted T incision?
It depends. Again, it depends upon if the baby, if there is a absolute transverse lie, so make it more liberal. So if just there is a high floating head, then it should be 3-4 centimeter. If it should be more than 5 centimeter if the lie is transverse. If you need more and more manipulation, the incision should be more. If you need less manipulation, let it be below 5 centimeter.
Sir, how to do manual rotation of fetal head occiput in fetal malposition in second stage of labor?
Abdominally, vaginally?
Second stage of labor, vaginally.
Vaginally. How to rotate the malposition of fetal head, or just to diagnose the malposition of fetal head, again, it is very important and very tricky. In neglected second stage, what will happen? There is a lot of caput.
Yes, right.
We fail to just see that sutures. Sutures on the vertex, sutures on the fetal head.
Yes.
So first put your 2 fingers beneath the fetal head, and pubic symphysis. You can easily you can easily feel the ear of that fetus. If your fingers are long, then you can easily palpate the ear of that fetus, and you come to know that this is the transverse arrest. If you go laterally, you cannot perceive anything, because there is a lot of cephalhematoma, a lot of caput. You cannot diagnose. You can diagnose just beneath the pubic symphysis. And if you are trying to rotate it, it will not rotate manually. You have to put forceps and then try to extract the fetus.
Yes, sir.
Sir, how to manage any abnormal bleeding at the placental bed after the placental extraction, sir?
Pardon, madam.
Sir, how to manage the abnormal bleeding, like more in quantity, at the site of placental bed after the extraction or expulsion of the placenta?
Yes. Now, suppose the placenta is morbidly adherent, and suppose the placenta is morbidly adherent, and you have delivered the placenta manually, or you have separated the placenta manually. That time there are chances of little bit excess bleeding from the placental side. First, see for the quantity of bleeding. If it is more, put a pack. Wait for a while. Then if that bleeding comes down, then nothing will happen. Just close the uterus, give some injection pause, and observe. One thing. Second thing, if the bleeding is torrential, it is not going to stop after being a pressure or anything. Try to suture that placental bed.
Okay.
Try to suture that placental bed, and if bleeding stops, then again wait and watch. And if bleeding still remains and it is excess in quantity, then think for the obstetric hysterectomy. Because such bleeding, bleeding of atonic uterus, it can be managed. But bleeding from placental side, always it is tricky. It may cause some problem after 6 to 7 hours. That time patient is awake, patient is drenched, maybe in the hypotension, maybe in the verge of DIC. That time if try to do something, then it will become a hell. Anticipate it. Just it is not going to stop. Putting a condom catheter, putting pressure, putting gel foam. These are the things to do in the institutes, not in private practice. In private practice, we have very limited resources. Once your anesthetic is gone, he will not come to help you. Once your assistant, and patient also. If you save some blood for the patient, they will not going to help you. Always, they are not going to help you. So try to anticipate the things on table.
Okay, sir.
Okay.
Priyanka ma'am, unmute yourself, ma'am.
Okay, sorry.
No.
Hello.
Yeah, ma'am, you're audible, ma'am.
Yeah. Sir, while the prolonged second stage of labor and with impacted head with the ruptured membrane, should we prefer the abdomino-vaginal delivery?
Abdomino-vaginal delivery. I have not tried, Priyanka.
Okay.
I have no any experience.
Okay. Sometimes what happens,
you can put light. If you have done, you can put light.
No, once I have faced that problem actually with shoulder and head deeply engaged, and at that time I just took the incision and delivered the baby with modification and making it a reverse. Transverse,
okay.
But only for one, because it was very difficult at that time. How means I cannot deliver that baby vaginally also, and I cannot even
abdominally.
So at that time, I have done that only one case in my life, but till now.
Yeah. We have to face very unusual cases. Someone has posted in our group, Nima Obgy group, the breach. There was one breach patient, and opened for the cesarean section. Hands were delivered. Someone is pulling. Legs are lying outside. Hands are popping out of incision wound. So why he has not tried for the vaginal delivery? I always had a question. I discussed it with 𝘿𝙀𝙇𝙄𝙑 sir also. The buttocks are always outside the vagina, and why he has tried for the?
She might be priming or something like that.
I don't know, but I think that extraction also became very difficult.
Okay, sir.
He has posted some photographs and videos.
Yeah, I know. I got it. I remember that post.
Yeah, I also.
Sir, what is your opinion for reverse bridge extraction technique? In which cases we should prefer?
A reverse internal podalic version.
Yes, not the version, reverse
bridge extraction
only.
In C-section, you are asking in C-section, no?
Yes, yes.
See, if the head is not coming, it is very much deflexed in poly, in the obese patient. Then if head is not coming, it is not in the range of forceps or ventos, then go for the fetal leg.
Yeah.
It will come easily. Never pull a hand. Always try to pull a leg.
Yes.
Pulling leg is very easy. Pulling leg is very easy than the pulling a hand. We keep
After
pulling
that
leg.
extraction of with even we can do with the Patwardhan method. So
No. See, if head is inside the uterine cavity, then there is no use of Patwardhan or modified Patwardhan. That baby will not come. Always you go for leg. If suppose hand comes, repose it, and then search for leg,
and then extract.
And then extract. It will come very easily. We often do in Sawantwadi. In Sangli, I'm not doing that. I'm happy with ventus and forceps.
Okay, sir. Sir, are there any requirement or use of tocolytics when the head is in the deep transverse arrest or impacted head, sir?
No.
Okay.
No.
Okay, sir.
See, once I have seen in deep impacted head, there was a lot of extension along with bladder injury.
Okay.
Along with obstetrician put his finger in between bladder and lower segment.
Okay.
And he tried to deliver that head. But head will not come. His fingers went into that bladder. There was major bladder injury. Somehow we could able to deliver that baby. And later on, I noticed that there was a big rent in the bladder. So this is what happens. See, in initial days, especially for the youngsters, but they don't know a lot of things, and they don't know how to tackle. They have enthusiasm, lot of enthusiasm, but with the enthusiasm, they don't know the maneuvers, and sometimes they may land up into problems. If they are lucky, they will get someone to help them. If they are unlucky, they have to face the problems. Always put some good people around you, so they can help you in the most needed hours.
Right.
Sir, from your experience, I would like to know which is more better, vacuum or forceps extraction during cesarean section?
Forceps.
Forceps.
See, what happens with vacuum? The uterine wall may entrap into in between the cup and fetal head.
Yes.
So it can injure. So you have to be very particular while applying ventus. This thing is not in a forceps. If it is not applied properly, you can reapply, na?
Yes.
Right. You can remove the forceps. You can take your time. You can reapply, and then you can extract.
So generally,
always get. Oh, yes, madam.
Continue, sir. You continue.
No. Just ask. I tell you.
Okay, I just want to ask, generally during cesarean section and while expanding the uterine excision, do you prefer only blunt with your fingers, or you take a forceps to extend that incision?
Uterine incision?
Yes.
Yeah. If there is more fibrosis on the primary gravidas, not formed the lower segment, space is less, that time I use scissor. Otherwise, I prefer to extend with the finger.
Okay.
Okay, sir.
Always get orientation of what situation is there. Yeah. Once you know this is the situation, then only you can do the appropriate maneuver.
So we found that while second stage of doing a cesarean section while the second stage of labor, it is more traumatic, difficult,
Yeah.
and people prefer to do it on the first during the first stage or
Yes.
when there is a less dilatation likewise. So
Yes.
what exactly how should we deal in second stage of labor?
See, in second stage of labor, extraction of fetus again is tricky. It is difficult. Lower segment is also sometimes it is swollen, sometimes it is very thin, sometimes it is edematous due to the prolonged stage of labor. We lost the plane into the bladder and lower segments also. Sometimes it is always it is edematous. Identification of tissue is important. If you are confident, you can identify or you can differentiate what is bladder, what is lower segment, what is vagina. Then it is not difficult for you to tackle anything happens there, you can tackle. But in the second stage of labor, see, always take incision above the uterovesical fold attachment or at the level of uterovesical peritoneal attachment. That will minimize, it gives more space and that will minimize the complications. If your incision, sir, namaste, good evening, sir.
Nice presentation. Whether you believe on the
काय म्हणतात त्याला काय तू इंटरनेटने काय सुरू दिलं नाही आज झालं ते
चालतंय पण मला वाटलं whether you believe on the single layer suture or double layer suture of the uterus.
Sir, I am a little bit old timer. I prefer to close everything what I have opened.
Okay. Thank you.
I always I do.
But uterus you take a double layer or single layer?
A double layer with peritoneal fold, everything. And what I have operated cesarean section, I have seen in the second time also. Incision is very good. 99 times. There are no adhesions, nothing. And I don't always. I try to not open the UV fold.
Okay. Generally, I use the single blade forceps for the delivering the baby instead of putting the hand, and that becomes very easy to deliver the baby head.
Okay, sir. Okay.
Just keep one blade below that, and
yes, it works as a vectis.
Yeah, like that. Okay, thank you. Thank you, sir.
Thank you, sir. Thank you. तुम्ही इतकं चांगलं हे केल्याबद्दल.
चांगलंच केलं, मस्त एकदम.
Thank you, sir. Thank you.
Then let us know, sir, whether you take interlocking or locking.
See, if there is
talking about the suturing, why not this question?
Yeah.
ऐका ना. What I feel की त्या टिश्यूचा गळा दाबणे हे मला आवडत नाही.
बरोबर आहे.
Locking means just to strangulate the tissue. Once you strangulate it, how can it heal, na?
Yeah.
So if there is excess bleeding, abnormal vessels are there, that time you can go for interlocking. If there is no bleeding, uterine incision is nice, then you can take a running, non-interlocking running suture, just simple suture.
Yes.
But instead of inverted T,
I think the healing is main thing. We should always think about the healing of the tissue. Always.
Yeah.
Though we are thinking about the hemostasis and all these things, but the second part is that healing of the tissue is also very important.
Yeah. I don't want to strangulate the tissue.
Right.
What youngsters, what they do, they try to strangulate it. They try to make more and more tight.
More pressure on that.
More pressure on that. Just they make it more and more tight. And in the second C-section, the scar is big, scar is thin. Sometimes there is
the ischemia of that region, particularly when we see after a few years.
Yeah.
And because it means it deal with some of the patient that comes with the ischemia and all what I have seen in my practice. So I think it is always better to think both of the part.
Yeah, yeah. Hemostasis also, and well healing also. Yeah. See, we have
Okay.
to see what I trying to say. We have to be very particular about choosing suture material, taking knots, deciding number of knots. These things are very important. If I am putting knot 6, 7, 8 on vicryl, what will happen? There is chances of infection. It is not advisable at all. See, if you take more knots, the tensile strength of suture become weaker and weaker. The more knots, it gives more and more space for bacteria to harbor there. There are a lot of chances of infection. It gives problem in the absorbing of suture. So take adequate knots. If the 3 knots are advised for vicryl, then only take 3. Nothing will happen. If you but take 6 and 7, definitely it will create some problem.
Okay, sir.
So you have to be very choosy while selecting your suture material. See, suture material has 20, near about 18 qualities. Suture material should have 18 qualities. Out of 18 qualities, 8 qualities are the physical appearance of the suture. If you use monofilament suture, the absorbing property of suture is more, fluid retaining property of tissue is more, everything is more. We have to think in that way also.
Also, sir, can you explain about suturing in inverted T incision?
See, first take the tail of T and then go for as usual.
Okay.
And
Okay,
write down in your notes, in your discharge summary, okay, I have taken inverted T.
Inverted T, yes,
patient.
yes.
Yeah,
yes.
if that
Right.
patient goes to another person,
Yes,
he can decide what to do. Yeah.
Sir, what are the conditions where we have to opt for a fundal incision, sir? Do we get such conditions? If so, what are the indications, sir?
Now, for the fundal incision or
Yeah, sir,
upper
fundal.
segment or the
Sir,
upper
completely
segment.
fundal.
Completely fundal incision, madam. I have no idea, honestly.
Okay, sir. And what precautions for the next cesarean section we have to take, sir? Is it very fragile or very friable? The scar tenderness would be more compared to the lower segment, or any extra precautions for this, sir?
With fundal incision?
Yes, sir.
No, I don't know. Yeah.
Okay, sir.
I have no idea, madam.
Okay, sir. Okay, sir. Okay, sir. Sir, what are the precautions to deliver the head during the preterm delivery, sir? When we see that there is a low birth weight and preterm.
I have seen for second video. In that second video, let allow the liquor to drain. First thing.
Okay, sir. Waiting.
Open up that uterine incision properly. First,
okay,
let the liquor drain out. Let the head come into the incision. See for the flexion, and then put your fingers in between fetal head, and then go for fundal pressure. This is the key. Or if the fetal head is very much deflexed, let's forget about the head. Go for fetal leg and make the internal podalic version, or just said madam there. Yeah.
Okay.
Okay.
Sir, do we have to advocate for a longitudinal incision for a preterm, sir, or lower segment transverse incision would do, sir? Hello, sir. Hello, sir.
I think it's network problem again.
Yeah, maybe, ma'am.
Yeah. Just message him once.
Yes, ma'am. I'll again call him.
Hello, madam.
Hello, sir. Yeah.
Yes,
We
sir.
can hear you.
Yes, sir. You're audible now, sir.
Pardon, madam.
That's okay,
आपने कुछ
sir.
क्वेश्चन पूछा था.
That's okay, sir. That's okay, sir.
सिंधु मैडम.
Sir, sir, I just wanted to know.
Please repeat the question for us, na?
Yeah,
Yeah,
ma'am.
yeah,
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 ma'am.
yeah.
Yeah, ma'am. Just wanted to know, sir, like in preterm delivery, sir, should we opt for a vertical incision or same as we do for all the cases, the transverse and lower segment would be done?
Yeah, lower segment.
Okay, sir. No need of a vertical one, sir?
No need of vertical. Vertical
Okay.
incision on abdomen on uterus.
Uterus,
or on both.
sir. On the uterus, sir.
No need to take any longitudinal incision.
Okay.
It can cause more and more bleeding.
Okay, sir.
If the placenta, suppose underlying that upper part of the uterus, then you can incise the placenta. You can injure the placenta, and again you may land up into problem. So always try to make it lower segment and transfer.
Okay, sir. Fine, sir. Sir, does the effacement of the cervix pose any problems, or does it have a role to decide the site of uterine incision, sir?
Effacement of cervix.
Effacement of cervix, yes, sir. Depending on. Okay.
Yeah. Again, if the cervix is less effaced, then the lower segment is less formed. It is thick. It can bleed more. If the effacement is good, lower segment is well formed, your seizure is going to be very easy in a well formed lower segment of uterus. Yeah.
How to do with the legs abducted position or the frog position, we can say. Means the wage vertex, how should we lift up that?
What, madam?
In the abducted legs abducted position or a frog position, we can say.
Yeah.
In that case, means how should we lift that wage vertex?
In C-section, no?
Yeah, during C-section. To reduce the injury to that fetal head and the uterus.
Fetal head, after you are talking about after coming head or just head first delivery?
No, I mean to say, means when there are we are quite impacted head inside that, and we have that extended legs. So at that time.
Okay. See, you go for modified Patwardhan.
Okay.
Yeah.
Yes, and that is easy, I think.
That
modified Patwardhan is becomes easy that time.
Yeah, 100%. That is going to be easy.
Okay.
I think we should conclude.
Yeah. Okay, sir.
Any more questions? Sindhu ma'am, do you find any questions?
Yeah, concluded, ma'am. Concluded the questions from my side, ma'am, and the audience also. Pooja, ma'am, if any.
No, ma'am.
Any questions are there?
From the audience, if any questions? You can ask now, the audience. Yeah. Finds like they have found their solutions, ma'am.
Yes.
All audiences are very experienced. So I think they have no any questions.
Yes, sir.
Yeah.
Ma'am, can we proceed?
We all are doing obstetric work, na?
Yes, sir.
We all we are all are doing so.
Yes, sir. Can we proceed to the vote of thanks session, ma'am?
Yeah.
Yes, ma'am. Yeah. Ma'am, a last question, sir. Which forceps should be used, the long blade one or the Killand forceps? There is a last question in the chat box.
Piper forceps is advisable.
Okay, sir.
For extraction of fetal head during C-section. But if you have Killand, if you have Wrigley's, yes, you can go with any forceps.
Okay, sir. Regland or Keeley is also fine. Thank you, sir.
Not necessary to have not necessary to have Piper forceps, because that forceps don't have pelvic curve. Okay, and we don't need pelvic curve in cesarean section. So
sir.
The Piper forceps is more appropriate. If you don't have, you can use Wrigley or Killand.
Okay, sir. Thank you, sir. With that question, we conclude the question answer session and we move on to the vote of thanks session with due permission of our dignitaries.
Yeah,
So
if any
with this-
questions will be there, the participants, they can ask on the YouTube also. They can put the
Yes,
questions
ma'am.
over there. We will definitely answer them.
Yes, ma'am. Later to that, it will be catered.
Yeah.
It will be answered to the participants for sure. Thank you. Thank you so much. So with this, we conclude the third national webinar by Nima Obgy Society Central, which was on the topic delivering fetal head during C-section and troubleshoots by our Reverend Dr. Shailendra sir. I now take the privilege in presenting the vote of thanks on behalf of Nima OBGY Society Central. I immensely and wholeheartedly thank our chief guest and our guest speaker, Dr. Shailendra 𝙀𝙀𝙀𝙍𝙀 sir, for his such an interesting and a brainstorming session. And it is our fortune to associate with you, sir, and move ahead in the light of your guidance. Thank you, sir, for your precious time and valuable presentation. Thank you once again.
Thank you.
Thank you, sir. I now thank the dignitaries of the Nima Central, President, Secretary, and the Treasurer, and also the dignitaries of OBGY Society, our President, Dr. Kamini Dhiman Madam, our Secretary, our very lively Dr. Priyanka Nakade Madam, who is an all-time inspiration for all of us, anytime and any date for that matter. Thank you, ma'am. I also thank Vishnu Bhavani sir, who guides us in all aspects, and an overwhelming thank you to all the dignitaries here. I thank Dr. Archana ma'am, who with her valued coordination, we could conduct this webinar today. Heartfelt thanks to Dr. Girish Daga sir and for his team for the technical support. And I thank all of them who directly and indirectly were a reason and an instrumental to make this webinar a grand success. I thank my co-host, my dear co-host, Dr. Pooja Kohli ma'am, for initiating and anchoring this webinar in such a great manner. Now, I thank all of you, my friends, who rendered your time and enthusiasm for this webinar to make this a grand success and seeking such same webinars, successful webinars in the days to come. Again, thank you one and all. Thank you.
Thank you
Dr.
all.
Sir.
Thank you, madam.
Thank you so much.